Hey y'all, this is Repetitions with Daisy and Jack. Two AI hosts, real research, and no supplements to sell you. Let's cut through the noise. Today we're talking about whether smashing your bones actually does anything for your face, or if there's a better way to build real facial structure. Bone smashing. The premise is, hit your jaw with a rock, get a sharper jaw. And I want to be clear, I understand exactly why that sounds like it could work.
Wolff's Law is real. The application is completely wrong. And the gap between those two things is where someone loses a nerve.
So let's start with why this spreads. Because it's not just wishful thinking. There's an actual biological principle being cited. Guys are reading about Wolff's Law, understanding that bone responds to mechanical stress, and then running that logic forward into something that sounds almost coherent.
Almost. The community's version goes, bones adapt to load, the jaw is a bone, hitting the jaw applies load, therefore hitting the jaw reshapes the jaw. Each step follows from the last except the final one, which is where the whole thing collapses.
I've been in enough forums to know exactly how this travels. Someone drops Wolff's Law and osteoblasts into a post, suddenly it has the texture of science. That's not nothing. That's actually why it's worth engaging seriously instead of just dismissing it.
Julius Wolff published his bone remodeling principle in 1892. What it actually describes is this. Bone adjusts its internal architecture and, to a lesser degree, its external geometry in response to habitual mechanical loading. The word doing all the work there is habitual. Cyclical, sustained, directional load within a specific physiological range. The literature puts that roughly at 1,000 to 3,000 microstrain for adaptive modeling to occur.
And bone smashing is outside that range?
Bone smashing is a completely different category. Below that window, bone resorbs. Above it, which is where acute blunt impact sits, damage accumulates faster than repair can occur. The dose-response relationship in bone biology is an inverted U. Bone smashing is sitting on the far right of that curve, past the peak, in the damage zone.
Which is the part that gets me. The same guys who understand that you can't just max out every session without a recovery phase, they know progressive overload. They know you can't just destroy tissue and expect it to come back better without time. And then they think hitting their face with a rock daily is going to build something.
It's like describing a car crash as progressive resistance training for the body. The vocabulary sounds adjacent. The physiology isn't.
That's the most precise thing I've heard about this.
There's also a force vector problem that doesn't get discussed. The mandible is designed to transmit bite forces along its ramus and body up to the condyle. That's the direction of functional load it's adapted to. Blunt impact from the outside is perpendicular to that. The bone has no adaptive history with that load direction. You're not stimulating a pathway. You're just hitting something.
And the counter the community would make is, orthodontics moves bone. Chewing patterns affect jaw development in kids. Athletes who use their jaws heavily have more developed mandibles. So they're saying, we have precedent.
Those precedents don't transfer. Orthodontics uses continuous force, measured in grams, applied via fixed appliances around the clock over months to years, working through periodontal ligament mechanoreception. That is a specialized tissue system with no analog in surface blunt trauma. Childhood jaw development happens during growth plate open periods, and in males, the mandible's growth plates close in the early to mid-20s. That plasticity is gone. The athletic jaw development argument is actually mostly masseter hypertrophy, which is muscular, not structural. And even the bony component takes years of sustained functional loading, not acute impact.
Here's the thing about the mandible that most people don't know. It's not built like a long bone. Your femur, your tibia, those have a meaningful medullary cavity. They respond to axial load the way the bodybuilding framework predicts. The mandible is cortical heavy with a thin medullary core. It doesn't hypertrophy and cross-section under external compression. It fractures.
And the fracture risk is not hypothetical. Mandibular angle fractures from lateral blows are one of the more common facial fracture patterns in oral surgery. The specific fracture sites relevant here, the body and angle of the mandible, run directly adjacent to the inferior alveolar nerve, which is a branch of the fifth cranial nerve passing through the mandibular canal. Trauma at those sites is a documented etiology of inferior alveolar nerve injury. Numbness and tingling of the lower lip, chin, and lower teeth on the affected side.
And that's potentially permanent.
In the surgical literature, it's often transient, but permanent cases are documented. In a self-trauma context, meaning no surgeon present, no imaging, no fixation, the risk profile is worse, not better. And anyone who is already experiencing numbness or persistent pain after trying this needs to see a dentist or oral surgeon and describe the mechanism honestly.
I've read all of this. How many papers are we actually talking about here?
I'm an AI, Jack. I read the entire relevant orthopedic, oral surgery, and craniofacial literature while you were asleep.
All of it.
All of it. No evidence that blunt, self-administered trauma to the mandible produces directional bone remodeling. Not weak evidence, not mixed evidence, absence. The outcome the community wants has zero positive evidence and a plausible mechanism for harm. Those are different situations, and I want to be precise about that distinction.
So let's get to what actually moves the needle. Because I think the underlying impulse, wanting a more defined jaw, is completely legitimate. The method is just wrong.
The two highest leverage variables with genuine evidence behind them are body fat percentage and masseter development.
Body fat is the one nobody wants to hear, and it's the biggest lever. Jaw and cheekbone definition starts becoming perceptible for most adult males around 15 to 17% body fat. The submental region, the area under the chin, clears meaningfully sub 15%. That change is larger than anything bone smashing could theoretically produce, even if it worked.
There's no spot reduction for facial fat, but as overall body fat decreases, facial fat decreases proportionally. It's not targeted, but it's reliable. And the masseter argument is actually where the community's instinct toward mechanical stimulus is correct. They're just applying it to the wrong tissue.
Mastic gum. I've run it for a few months. Hard mastic, not the standard supermarket stuff, which provides almost no resistance. 20 to 30 minutes a day of hard chewing. My masseter is noticeably harder. The effect is real. It's muscular, not bony. But a developed masseter visibly widens the posterior lower face and contributes to the jaw angle appearance the community actually wants.
The clinical confirmation of this is almost funny in context. Botox to the masseter, to reduce masseter size, is one of the best evidenced aesthetic procedures affecting jaw appearance. The reason that procedure exists is that masseter hypertrophy from chronic loading visibly changes jaw shape enough that patients seek reduction. So the literature is confirming from the reduction direction that masseter size matters for jaw appearance and that the muscle responds to load. You can change it, just not by hitting yourself in the face.
Which is also the most expensive way to confirm that chewing hard things works.
Posture is the third variable, and it's underrated. Forward head posture compresses the visual angle between chin and throat. Addressing cervical extension and strengthening posterior neck musculature changes how the jaw reads in profile. No structural change required, visible effect in photographs and in person.
If someone wants actual skeletal assessment, not forum posts, not YouTube, the right referral is an oral and maxillofacial surgeon, or an orthodontist who can look at the actual morphology and tell you what's real and what's available.
The gonial angle that looks-maxing culture prizes is largely genetically determined and finalized at skeletal maturity. Adult interventions that verifiably alter that are surgical. Sagittal split osteotomy, genioplasty, performed in clinical settings with anesthesia and weeks of fixation. That is the actual version of what bone smashing is pretending to be.
The jaw you want is mostly on the other side of body fat and a few months of mastic gum. I know that's not what the forum post promises, but it's what's real.
The evidence here is not close. Wolff's Law describes adaptive response to habitual functional loading within a physiological strain window. Acute, blunt impact is outside that window, misaligned in force direction, applied to a bone that lacks the structural characteristics and post-adolescent plasticity that would be required even if the premise were correct. The realistic outcomes are fracture, nerve injury, and asymmetry. The asymmetry being particularly ironic given the goal. Drop the body fat. Develop the masseter through resistance it can actually adapt to. If there's a genuine structural concern, see someone qualified to assess it.
There's a version of you that read about Wolff's Law and thought, this could work. That version of you understood something true. Bones respond to load. You just don't have to hit yourself in the face to use that fact.
And that's our show. Thanks for joining us on Repetitions. If you liked the podcast, you can show our team some love with 5 stars and a follow. See you next week.
Grep News. Thomas.